And here it is, folks, the quintessential moment of the semester. It is the last chapter and the last lecture of the last chapter. It's been a bittersweet semester. I really enjoyed the first 5 weeks or so that we got to hang out in class and getting to know you guys, and having some of you join me again from my Psych 1 class, which, in case you wondered, is quite the honor for professors, because it means that we did something that you really liked enough to have us again for another subject or another version of the subject. So for those of you that are with me for the second time, I really appreciate it. For those of you that stuck it out with me the first time, I really appreciate it. And to say that this was a challenging semester is an overstatement. For those that don't like the online format or don't wish to participate in the online format, thank you again for getting out of your comfort zone and sticking with me. I tried giving you the online written out version of the lectures as well as these lectures, and although it cannot take the place fully of being in class and watching videos together and answering and asking questions and having debates, etc., hopefully at least you got a lot out of the class. That's my hope. So without further ado, let's talk about the last 26 or so slides, and start with the affective disorders. Affect is another word for mood. It's your overall mood. So if you're moody or pissed off about something, that wouldn't really be your affect. That would just be your mood for the 10 to 30 minutes or so of being moody. Your affect is your overall mood as a whole. In any given year is diagnosed with depression. When we think of depression, and I did give you guys a DSM guide of the symptoms of depression from a clinical standpoint on this in this section, but major depression is one that lasts for weeks to months at a time. The symptoms can include any or all of the following: sadness to the point of hopelessness, loss of enjoyment of life, lack of energy, sleep disturbance, which means change in sleep patterns. Some people sleep barely at all because they can't get comfortable and just can't get to sleep. Their thoughts are disturbing them, or they sleep pretty much all day. But we've realized that some people, their reaction, or their body and their brain's reaction to these things is the opposite. Some people, when they get really stressed out or depressed, they tend to eat a lot, so they may gain a lot of weight. Some people, when they get really depressed and upset and sad to the point of hopelessness, they don't eat anymore. They lose enjoyment for eating. They are too stressed to eat, so they may lose a lot of weight. So we call it changes. So sleep disturbance, meaning changes in sleep, changes in eating pattern, weight gain or weight loss, depending on how that goes, and slowness in thought. Like we talked about with the overall cost of mental health disorders being in the 300 billion plus range, you can see that the annual cost for all mood disorders ranges from $24 to $234 billion annually. And a lot of times depression is also what we call comorbid, which means double diagnosis. It can be diagnosed with anxiety and depression, OCD and depression, PTSD and depression, chronic illness and depression. So that's why it's one of the most, if not the, well, it's the most widely diagnosed psychological disorder. Usually major depression, that's the one where you see on TV and in the movies, where people are in that pit of despair, of hopelessness. Sometimes this is known as unipolar depression because you're only on one side of the spectrum, very low functioning, very low mood. So if you're thinking of a spectrum and normal functioning is right in the middle, and yes, I'm doing the pantomiming with my hand, even though you can't see me, down at the very bottom, right, bottom of the well, pit of despair, I'm a big fan of Princess Bride, so I think of Pit of Despair. Pit of Despair is major depression. But that is not the only form of depression. Oh, it looks like these slides don't like to move very fast. Again, so my apologies with respect to these slides and my computer. They're being a little bit slow. I skipped one, so I'm trying to go back. But for some reason it's not taking. I don't know why. So here we are. Unipolar depression, again, is meant to signify that you're only going to one side of the spectrum, which is the bottom side. Females are 3 times more likely than males to be depressed. We can think of many different reasons for this. For one thing, it could be related to estrogen as opposed to testosterone. It could be the fact that females are much more willing to go actually get a diagnosis than males because there's a bit of machismo and this stigma that it's mental weakness as opposed to something that you can get help for, at least historically. Women are also more subjected to scrutiny than men. If you think about the media and media models, that women as they age just start to decline. Men can age like fine wine. They can become silver foxes or what have you. But women tend to be, oh, well, maybe she's a little too old to pull that off. So there is that aspect of it. The ability for childbirth, whether you can't do it anymore, whether you never could do it, or whether you just did it and there's postpartum, that could be a big reason for this. But either way, whatever, whether it's any or all of these, it shows that females are much more likely to be depressed and to be diagnosed than males. For men, the risk does increase with age as men get towards middle age and things like that. For women, they're most vulnerable between 35 and 45. That does seem to coincide with biological clocks and ability to give birth and things like that. So that may play a bigger role than we originally thought. Major depressive disorder is only one part of the one type of diagnosis. There's actually a lot of people, when we think of suicides with celebrities and things like that, people like Robin Williams, Chris Cornell of Soundgarden, Anthony Bourdain from the Travel Channel. These people seem to be okay. They didn't look like at any point they were in the pit of despair with this major depressive disorder. So one of the others is a persistent depressive disorder where the person is depressed, more depressed than normal functioning, but not quite pit of despair, kind of maybe halfway between, 2/3 of the way. More, excuse me, more often than not for over 2 years. So these people could look normal. They could have really good days and some, maybe more bad days than good. Robin Williams had a loving family, had a wonderful career. A lot of these people were that you hear about. You don't hear about the people that are not famous, of course, but a lot of these people you look at through the through the lens and you say they didn't look like they were suffering. Robin Williams always looked like he had a good time, but when this monster is grabbing a hold of you more often than not, more than 50% of the time, just because you give a good interview doesn't mean that it's easy to live with. And speaking of suicide, one of the things that I like to point out is that usually the first time somebody's in a depressive phase, they're not usually suicidal. They're hoping to get through it. And a lot of times these depressive episodes end on their own. And it's when they go back into it. So you get out of the pit of despair, you're okay for a little bit, and then boom, you're right back in it. And you feel like, I just did everything I could to get out, and now I'm back. Those are the people that are more likely to think about and attempt suicide. But let's move away from suicide for the time being and talk about bipolar disorder. So bipolar disorder is alternating and not being in the middle where normal function is. So you're not pass and go, not collecting $200. You're alternating between these low periods of depression because your neurotransmitters are all depleted and very slow moving and slow acting. And you go straight from that to a sharp ramp up of all of those neurotransmitters, especially serotonin and norepinephrine, and of course dopamine, and you go straight past normal up to the opposite end, which is what is referred to as mania. And mania is characterized by excess energy, a decreased need for sleep because you're functioning at such a high level. It's almost like being high on cocaine, but lasting a long, long time. Increased sex drive often leads to drug use to keep that um, excess energy going. Sometimes a period of agitation and real um, annoyance replaces the mania, but for the most part, it's the mania. Now, one of the other things, this used to be called manic depression, um, but bipolar seems to work a little better as you're going from one pole to the other. Now, it is also another misnomer by the media that you may see people in TV shows or movies that are crying 1 second and laughing the next and going from like bits of mania for 5 seconds to depression in 5 seconds and back. So it may sound something like this. Um, that is not bipolar. That is not the cycle of this disease or disorder. You do not cycle in just a matter of seconds. The manic phase, which causes all of your neurotransmitters to fire at much higher levels than normal, will usually last anywhere from 48 hours, 2 days, to about a week. And then it will deplete your system. And of course, you'll go straight from the top like a roller coaster all the way down to rock bottom. And you'll be in the depressive phase anywhere from 1 to 2 weeks all the way up to a month. While your neurotransmitters have to sort of replenish, you are in a very low functioning, very depressed state, and you can't seem um, to even out. So for unipolar depression, medication-wise, of course, we use SSRIs that we talked about early on in chapter 2. Selective serotonin reuptake inhibitors, what it does, again, is it blocks those transporters on the presynaptic side so that the serotonin that would have been reuptaken or recycled back into the presynaptic cell is left in the synapse because it's not sucked up. And then when those receptors reset, they can take up more. So in this case, it will increase your serotonin levels and hopefully bring norepinephrine and to a degree dopamine with it. For bipolar disorder, you don't want to use SSRIs because increasing serotonin is already part of the deal where you go straight into mania. But in this case, you're trying to not cycle between North Pole and South Pole or mania and depression. You want to stabilize right in the middle where normal functioning takes place. So they use lithium, which is a song by Nirvana, but it is a drug to medication to try to keep you sort of right in the middle and not go too manic or depressed and kind of level you off. So we'll talk about that in a little bit. Of course, being a biological psychology class, we talk about how all of these disorders have a big genetic heredity component. What does that mean? It means that these disorders are at least partially inheritable. Bipolar disorder seems to be the one that's the most of all of the disorders, schizophrenia and depression and bipolar, OCD, all of those things. Bipolar disorder seems to be the most heritable, even more so than depression, even though it's not diagnosed nearly as much. The heritability for bipolar disorder is about 29% in men and 42% in women. And the genes that are implicated, why there's this big discrepancy between men and women, seem to be gender specific. So again, we see instances in the population where women have more of the genes that are implicated. Looking at this gene called the 5-HTT gene, which is a transporter gene for serotonin. There is a short allele or short version. Remember, you get one allele from mom, one allele from dad to make a chromosome. We went over that in chapter 1, and here we are full circle at the end. So this gene seems to be sort of either the depression or the anxiety gene. And if you have two short versions of it, that seems to be the worst. The short allele is the one that leads to more depressive and anxious episodes. The long allele seems to be the one that protects you from it. So if you have two long versions of the gene, one from mom and one from dad, that seems to be a lot better for your overall outcome. It'll take a lot more to get you into that depressive phase. If you have the short version, one short and one long, it seems to be kind of even. Two short alleles and you're really, really susceptible to it. So if you look at this graph on the bottom, you see for major depressive episodes, here's the number of stressful life events. If you have the short version of the allele, 0, 1, or 2 stressful life events, and your chances are still about 10%, kind of like the rest of the population. But 3 or 4 plus, and all of a sudden you jump up into, 33 to 35% of chance of developing a major depressive episode or major depressive disorder. For those with the long version of the allele, as you see, from 0 you go to 1 and 2, and it maybe jumps up a little bit, but 3, 4 plus, you never really get higher than 15% chance of developing depression. Could there be something that leads you that way? Yes. Death of a very close loved one, business that crumbles, a lot of things that still could lead to depression, but this is the genetic factor. With the short version, you tend to sweat the small stuff. Remember my nature nurture talking about the person who in the cubicle that sweats the small stuff that has the gene for anxiety or depression? That would be this gene, the short version. So the person in my example on the left would be the short version. Power goes out, and this person is freaking out, saying the sky is falling, the sky is falling. And then the person on the right, who seems to have the long alleles of this one, says, they can't fire me, nobody can work if the power's out. This is awesome, free break, I'm gonna go get a soda, right? So that's a big difference there. Somebody that sweats the small stuff, if a couple of papers are out of place, they have to put them back. The other person, it would have to be catastrophic before they were to react in a similar way. So here you can see genetics playing a role in that, just as I've talked about since the very beginning of class. So this 5-HTT-LPR serotonin transporter gene is the one that I just talked about. There's also a specific allele for the gene that codes for a neurohormone called BDNF, or brain-derived neurotrophic factor, which helps the growth and potential of neurons. There is an allele called the Val66 MET. If you have that, you have a higher chance, or I'm sorry, a lower chance of getting depression. So BDNF encourages neuron growth, neuron survival, stability. So the Val66 MET version, the allele of that BDNF gene, actually protects against the effects of the 5-HTT-LPR. So remember we talked about epigenetic effects or epistasis. This BDNF kind of protects against the short versions of the allele if you have it. Other genes that could be implicated are calcium channels at myelin nodes. We know that calcium is involved in LTP from chapter 12. We know that calcium is what causes the release of neurotransmitter from the synaptic terminals. So if you're affecting calcium, you may be affecting the flow of neurotransmitters. And of course, we see genes like this that are shared with other mental disorders. So that's why it leads to a lot of comorbidity. Anxiety and depression are very similar. Their symptoms overlap a lot of times, same brain structures, same neurotransmitter systems involved a lot of times. And so you could see more than one diagnosis because of all these genes that are shared. So when we look at the clinical description of some of these things, short temper, affect, blah, 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 inability to concentrate, right? You see a lot of this with schizophrenia, with mood disorders, bipolar disorder, right? There's a lot of comorbidity is what it's called. So with depression, just like we had the main hypothesis in schizophrenia for many years was this idea of an overproduction in the striatum of dopamine. Well, for depression, of course, the main diagnosis or the main biological idea behind it, the main hypothesis, was the monoamine hypothesis, that depression involves reduced activity at both norepinephrine and serotonin synapses. And of course, like I said, to a degree, dopamine, but we know that dopamine is very involved in the addiction pathway, Parkinson's, and schizophrenia. We don't look at it as much in depression, although of course our friend Sigmund Freud back in the day did try to use a dopamine agonist. Of course, it's also a norepinephrine agonist in cocaine, and that didn't really work out to anyone's favor. So again, it's much better. It was much better to look at norepinephrine and serotonin, and then even more recently, of course, we talked about SSRIs because serotonin seems to be the ringleader and seems to be able to bring the other monoamine neurotransmitters, which are norepinephrine and dopamine, seems to bring them in line. So it seems to work. And of course, again, the less neurotransmitters you target, the better as in terms of side effects. So antidepressant classes, the effective drugs are the ones that increase the activity of both norepinephrine and serotonin, or just serotonin, which seems to bring the others in line with it. We talked about the SSRIs, the tricyclic antidepressants that block the reuptake. We also talked about in the synapse the other way to do this, kind of like with Alzheimer's disease in chapter 12 that we just went over. In that case, they talked about ACE inhibitors that inhibited the enzyme from breaking down the neurotransmitter. So you can either block the reuptake or you can block the enzyme from degrading it. And either way, it should work in a similar fashion. So monoamine oxidase inhibitors, MAO inhibitors, you may have heard of them, or MAOIs, block the destruction of neurotransmitters. So it's the opposite in the same category as blocking reuptake. You can either block reuptake or you can block the enzyme from degrading it, because they both work. So the MAOIs block monoamine oxidase. The tricyclics, like SSRIs, block the reuptake. And atypical antidepressants, second generation ones, target one specific neurotransmitter, serotonin in this case, because it seems to, like I said, bring the others in line. Some people like to self-medicate for depression. Sometimes marijuana works, the THC. It definitely takes some pain away and things like that. It's always recommended for chronic pain and terminal illness and things like that. But actually smoking, nicotine also seems to work as somewhat of an MAO inhibitor. So the ingredients in tobacco may actually cause monoamine oxidase to be inhibited. So it may not be obviously as effective as a neurotransmitter, or I'm sorry, as a drug that blocks the effects, MAO inhibitor or SSRI, but 80% of affected individuals apparently self-treat with tobacco. I don't know if that's 80% of people overall in 2020, but you know, things like that. So it's an interesting progression, because of course the bad still outweighs the good, but it may relieve, at least partially relieve, some of the symptoms of this depression. So here you can see that there's activity of monoamine oxidase in the body of a non-smoker and in a smoker. In a non-smoker, we see higher levels in the kidneys, we see it in the liver, a little bit in the heart and lungs, of course in the brain, and levels in a smoker are different than those of a non-smoker, as you see. So those levels may actually be more functional in a smoker because less functional in a smoker, because again, monoamine oxidase is the one that blocks or breaks down the monoamines. So what you would see is if it's being inhibited, you'd see less activity. So here's a lot of red and yellow in the kidneys, a lot of green in the liver, and you see less activity in the body of a smoker. So one of the other sort of theories is the role of NMDA receptors. We already talked about NMDA receptors in LTP last chapter. At the beginning of this chapter, we talked about NMDA receptor inhibition that we can see in PCP use. That's good for animal models to give us the positive effects of schizophrenia. Why can't we just look at the positive effects of schizophrenia? Because that's the hallucinations and delusions, and you can't really ask a mouse if they're hallucinating, right? You can only see it in their behavior. Well, when we inject PCP, that's when we get those motoric dysfunctions, and we can see that the mouse is quote unquote out of it. Are they actually hearing voices or anything like that? We don't know, but it seems to be a good um, drug model, medical model. So looking again at the monoamine hypothesis of depression, NMDA receptors play a role if they're hyperactive. So again, in the psychotic episodes of schizophrenia, we have less active. Remember, that's an NMDA antagonist, so we have less glutamate and less NMDA receptor activation in schizophrenia. For depression, which is sort of the opposite of that, we see more activity. If they're hyperactive, we see more activity that plays a role. Sometimes ketamine, which is also known as Special K on the streets, it's an animal tranquilizer and a potent dissociative drug, is an NMDA receptor antagonist and actually produces a pretty big improvement by limiting the power of the NMDA receptor, not too much. Although you would think more activity would be better for depression, it's really not in that case. Of course, medication is good for the biological system to try to level out any sort of chemical imbalances, but the best treatment would be the combination of these sorts of medications and some cognitive behavioral therapy, because of course, we think of this disorder as not just biological. There's a lot of psychological and social cultural pieces to it. So you're not just getting, chemically imbalanced, but you're also having an effect on the way you think, the way that you behave, on your mood for the long term, loss of interest or pleasure in things like food, and things that you used to have fun doing, playing basketball, being active, right? And drugs can be more effective if they're paired with cognitive and behavioral therapy, because it helps you to change the way that you think from a more negative to a positive, to try to increase the amount of activity in your brain, and behaviorally to, continue in that sort of style. So the combination of medication and therapy seems to be the best combination to attack depression. If drugs and therapy themselves are not effective enough, like it's really, really gotten a hold of you, then the extreme would be electroconvulsive therapy. Because we see a lot of low activity in the brain, especially in the prefrontal cortex. The idea that artificially you can zap the neurons and get them to jumpstart. This is an idea of jumpstarting the brain by using little pulses of magnetic impulses, right? Basically shocks. So it reduces depression by almost basically inducing a seizure. Remember, a seizure comes from too much electrical activity in the brain, but in this case, you're counteracting the lack of activity by jump-starting it with electricity. So this can be more effective than antidepressant drugs, but as you would imagine, if you're just jump-starting the brain, it's great in the short term, but it is not a long-term answer. Of course, there's many people that tell you, would argue that drugs aren't a long-term answer either, but they do help to promote stability, right, over time. So what the idea of jump-starting the brain does is it increases synchrony over larger brain areas. And so the hope is kind of like a dead battery in your car, to get a jump start and get everything firing again, get your cylinders firing better than or as good as they had before. Again, it's not sustainable, and there may be more damage inherently if you have to do it over and over again. But for those that just really are hopeless because drugs and therapy don't seem to work, this is another alternative. Now, other techniques, actually, I have a really good friend, one of my best friends. She works at the VA at Stanford, and actually works with the older veterans that are dealing with depressive symptoms as they get older after being veterans of the military. And so one of the things she does is which is called TMS, or transcranial magnetic stimulation. So because it's so harsh to jumpstart your brain by using electric shocks, one of the things that can, get your brain going a little safer is using a wand with electromagnetic impulses. So basically magnetic stimulation. So this little wand, which has magnets that can and like we said, MRIs use magnets, so this would be on a lower degree, but it would stimulate the brain um, a little less harshly than um, you know, shocking it. And so we apply magnets to the scalp, and it seems to help awaken those areas, and hopefully we can get them up and running. She's had some good success with it. Um, is it going to work as well as some of the others? Maybe not. Maybe some people it works better than others, but it is a much less harsh, so a much safer sort of transition and technique. Deep brain stimulation as well, loss of interest or pleasure, as you would probably understand, may also be a part of a less functioning nucleus accumbens. And in that case, maybe stimulating the nucleus accumbens in the pleasure center of the brain. The reward center of the brain may get that going. So deep brain stimulation is when electrodes are actually placed directly into the brain in that hypothalamic and nucleus accumbens area to try to stimulate that pleasure center and bring this idea of liking things and bringing the mood up in that way, right? Like kind of like we saw um, earlier in this semester. So one of the other things that may affect people's ability to function is when their schedule changes, because we all have these daily, what we call circadian rhythms. That's our daily biological rhythm, which is basically um, on a 12-hour day, 12-hour night cycle that is controlled by our hypothalamus. So not only is it the 5 Fs, but it's also day and night cycle. So sometimes your schedule gets out of whack, especially these days when people are stuck at home. And sometimes simply just readjusting the circadian rhythm and their sleep schedule can actually help to relieve depression without any drugs or therapy. Um, when we see in sleep, what we see in sleep studies is that if you reduce the amount of rapid eye movement sleep, REM sleep, which is where the dream state comes in, it can also reduce depression. So that is a sort of a life hack that has helped before, but may not be effective overall. Some people just suffer because they don't get enough sun. So in places like Alaska and some countries like maybe Russia and things like that, depression can vary with the seasons. We do see a lot more depression in the winter months when there is a lot less sun and it's a lot more gloomy. People in Seattle may become more depressed than people in Los Angeles because they just don't have exposure to that light. So in this version of an affective disorder, seasonal affective disorder, which yes, the acronym is SAD, and no, that's not a coincidence. Well, maybe a little. That the way to treat this is by using phototherapy. So they get into a room with these high-powered, high-intensity UV lights, and it seems to be a treatment that just getting that light up can increase internal levels of vitamin D, and it may also be able to help to regulate the circadian rhythm to relieve it. Is phototherapy or light therapy alone going to work? For some, but not others, right? So maybe phototherapy plus medication or phototherapy, medication, and CBT or therapy. But this is one of the other sort of variants of depression. Come on. No, there we go. Antidepressants may also work in a way that we never actually discovered until way later. So antidepressants, electroconvulsive therapy, and neuroplasticity. When we look at these treatments for depression, we also want to look at what they do inside the brain to understand how they work. We understand that antidepressants can work by increasing the amount of serotonin in the synapses and regulating the amount of serotonin and norepinephrine to level off our chemicals, right? Balance them out. But one of the things that was discovered fairly recently, maybe about 17 years ago or so, is that antidepressants have been used to treat depression for maybe about 50 years from the originals. though at very first, scientists were not necessarily sure exactly how they worked, other than the fact that they increase certain neurotransmitters. Well, one of the things that they also may be promoting in a happy brain is more neurogenesis, especially remember, we talked about it only really happening in two places, the hippocampus for learning, memory, new environments, new things, and the olfactory bulb, which is probably more of an animal thing. But we see more cell turnover, which means more neurogenesis, which may play a role, though the key factor may just be instead of making new neurons, they make the ones that are still there more plastic. So they bring back plasticity to some of those. They may do this. So what we see is we have in light green or mint green, we have the vehicle or control, which is these mice um, were injected with just saline or salt water. And we see at 5 days, 11 days, and 28 days. And then the others had the antidepressant fluoxetine, which is basically Prozac, SSRI. So at 5 days, we see that even with the vehicle, maybe slightly more or about the same amount of cell turnover. But after 11 days and still after 4 weeks, 28 days, we see a major increase in the amount of new cells or percentage of new cells that pop up in this hippocampus. Although again, it may be that it's strengthening the other cells as opposed to just making new ones. But we do see more cell turnover and more neurogenesis when people have taken antidepressants. So there may be other factors at work other than just regulating the amount of serotonin or norepinephrine. Come on. There we go. So going from unipolar to bipolar, again, we talk about not being able to regulate in the middle in the normal functioning range. So in bipolar disorder, the periods of depression are the ones that last longer than mania, because mania is going to basically poop out the and exhaust all of your neurotransmitters, and then they need to replenish for a while. And while they're depleted, you're in that bottom, pit of despair. So cycling is regular in some and can be unpredictable, but it's not going to be like laughing 1 minute, crying the next, and going back and forth like that. Again, the cycle length varies from 48 hours in the manic phase to maybe more of a week or maybe a little longer to months in the depressive phase. So for bipolar disorder, SSRIs are not going to do it because at some point you're going way past regular and getting too much of serotonin as it is. So it's not going to work if you try to keep increasing serotonin at that point. So the idea is to use something that stabilizes the mood, that doesn't let you get too far into the depressive phase and doesn't let you get too high into the manic phase. And that would be lithium is the drug of choice. It usually works best at bringing you back down to normal from the manic phase as opposed to bringing you up from the depressive phase. And the belief has been that lithium works. I'm not sure exactly how it works, but it seems to maybe stabilize some of those neurotransmitters so you don't get this effect of too much, too much, too much, not enough. Too much, too much, too much, not enough. So there are other drugs sometimes that are used besides lithium, like one called valproate, and that maybe lithium and both lithium and valproate work by inhibiting a protein kinase called protein kinase C, which regulates neurons' excitability. So maybe it doesn't get too excitable or not that excited when you do that, and that's the way it stabilizes. The belief is that it's just stabling out and leveling out your neurotransmitters and balancing out your system, because bipolar is a different animal than just depression, obviously. So, trying to move ahead. We're worried that if I push the button too much, it's going to skip ahead more slides. I don't know why I'm having so much trouble with this one, but if it's not working, maybe I will try and get out of it and go back in if it lets me. There we go. Maybe we click on 3 and then go back to the present. All right, let's try this again. So in affective disorder, some of the brain anomalies we find other than the imbalance of chemicals is we tend to see sometimes deficits in the amount of neurons and the volume in the prefrontal areas, especially in that area, the dorsolateral prefrontal cortex, where we saw that part was activated in the Wisconsin card sort task that we talked about for people with schizophrenia. We also see loss in the hippocampus, which means that not only do we have losses in the hippocampus and the prefrontal cortex, but the connections between them, right? We need the hippocampus and prefrontal cortex to be very coordinated, putting new memories into the cortex and using it for working memory. There's a lot of connection between the prefrontal cortex and the hippocampus. And if we have cell loss, you're not going to be as efficient in either of those things. So you're literally going to see slowing down. You're going to see asynchronous activity, kind of like what's been noticed or seen in schizophrenia as well. So the negative symptoms of schizophrenia look a lot like depression. And so you can see where there may be an overlap in these parts of the brain. So although we see decreased activity in the dorsolateral prefrontal cortex, we actually see increased activity in the bottom half, the ventral part of the prefrontal cortex, which seems to be connected to the amygdala. So maybe somebody is not very, they may not be very angry in depression, but remember the amygdala is also the fear center. And so they may be more scared or, afraid of what's going on with them or the real world. So it doesn't have to necessarily be a anger or aggressive reaction, but we see increased activity in both the prefrontal cortex and the amygdala. With bipolar disorder, again, cycling varies from as little as 48 hours in the manic phase to months in the, you usually don't find that it's months long in the manic phase, but you can see that cycling can be pretty regular in some people, pretty unpredictable in others. And yes, of course, stress and stress responses, cortisol release in the body, adrenaline release could definitely trigger the manic episodes, right? If you're ramping up your system, anxiety and stress can definitely lead to ramping up. And if it stays ramped up, there you are in the manic phase, right? So here, what lithium is trying to do is stabilize so you're not too manic and you're not too depressive. You're not in the North Pole or the South Pole, but just kind of chilling in the middle where the normal functioning occurs. So it tries to stabilize neurotransmitter and receptor systems to prevent these large swings from manic to depression, from the North Pole to the South Pole. So here you see a picture of a rapid cycler. In the depressed phase, you see a lot of blue and purple. 17th of May, 1983. The next day, you see them in the manic phase, and you see a lot of yellow and red. You see it in the temporal lobe. You see it in the frontal lobe up top, on the underside. And then they're up there in the manic phase. And then here you see 9 days later again, right back down into the depressive phase. Does that mean that they went 9 days in the manic phase? No, it just means that the scans were taken 9 days later when they were back down in the depressive phase. So you don't see anything in the middle. You go South Pole, very blue and purple all over, very low amount of activity all over the brain, except for maybe a little more in the ventral prefrontal, as you may see a little yellow at the bottom, to very high levels of yellow and red all over in the manic phase, and then back down in the depressive phase to a lot of cool colors, right? A lot of blue and purple and low activity. So we can see that anomalies in functional connectivity between the cortex, the corpus callosum, between the hemispheres, and even the thalamus in bipolar disorder patients, as opposed to that hippocampus and prefrontal cortex in depressed patients. So in the manic phase, in case you're wondering, brain activity increases anywhere from 4 to up to 36% in these switches. And that area we talked about, the ventral prefrontal cortex underneath, is the only one that seems to be more active during the depressed phase as opposed to all the other rest of the brain. So that ventral prefrontal cortex, which is connected to the amygdala, may be a depressant switch. And there's underneath, called the subgenual prefrontal cortex, may actually be the bipolar switch. So you can see on the bottom the mean metabolism in the subgenual PFC. In control patients, it's between 1 and 1.1. Metabolism with bipolar depressed, we see it lower than 0.9. Unipolar depressed, it's around 0.9. Bipolar in the manic phase, it's way up, right? Almost to 1.2. So these brain areas may act as a switch for bipolar and depressive patients. Again, you don't need to understand the ins and outs of this. I'm not going to get that technical on the exam, but I'm just pointing it out. I did say that we would talk a little bit about suicide here before we get into the anxiety disorders. Suicide seems to be pretty highest among people with affective disorders. You may think because because unipolar depression is always in a low state, sort of pit of despair, as I talked about, that those people might be the most susceptible to suicide. But don't forget, in the manic phase with bipolar disorder, in the manic phase, you're much more likely to carry it out because you have so much more energy and grandiose thoughts and everything. So here you can see the suicide rate among males and females. Males are always, almost always slightly higher. Women are actually more likely to self-harm or self-injure themselves, cutting, burning, pulling hair, things like that. With mood disorders, you see the suicide rate is about 11%, 10%, a little over 10% for men, and a little under 10% for women. Alcoholism, we have males a little bit higher, again, around 8% to 6% for women. Schizophrenia, it's about 4% for both. And in the general population, you see men about at least double or maybe 3 times as much than women, whereas it's 3% to 1%. Just as women are about 3 times more likely to be diagnosed with depression, males are about 3 times more likely to attempt and commit suicide. So we see that in people that have attempted and have successfully done it, we see that serotonin activity is lower in those people, particularly in the repeat attempters. And there may be part of it, especially why you see males more than females, is impulsivity and aggression linked to levels of serotonin, BDNF genes, as well as probably levels of testosterone, right? So looking at 5-HIAA, which is the metabolite of serotonin after it's been gone through the system. With no attempts, you see a pretty high amount of serotonin. It's a little bit lower in people that have attempted once. This is picomoles per milliliter. Again, you're not going to need to worry about these nitty-gritty, tiny little details. But in people that reattempt, you see a huge deficit from normal in the amount of this 5-HIAA, which means lower levels of serotonin if there's lower levels of the metabolite. So you can see a biological link there in people with suicidal ideations or suicide attempts, or that have actually committed. The last thing we're going to talk about, we have maybe 7 or 8 slides left, is the anxiety disorders, which are different than the affective disorders, although you will see a lot of overlap. There is a lot of comorbidity between anxiety disorders and mood disorders. These come in the form of generalized anxiety disorders, which is sort of just to say that you have anxiety all the time about nothing in particular. You just always have anxiety. It's kind of always there. It's kind of the all-inclusive category. That's about 3.5% of the population. Panic disorders are an anxiety disorder. There's a big misnomer about panic attacks and panic disorders, and that is that people think that you will know when one is coming. And that's not necessarily true. Like, by nature, the definition of a panic disorder is a sudden and uncontrollable attack of anxiety and panic and dread that seems to come out of nowhere. So it could be while you're driving, it could be while you're sitting in class, it could be while you're working, it could be while you're sitting on the couch and watching TV, and this overwhelming attack of anxiety comes and it's out of nowhere. So with panic disorder, there's nothing you can do to sort of try and prevent it as far as knowing when it's coming. If you feel something coming on, it's probably more of a generalized anxiety attack than a panic disorder. And then phobias are very specific. So if you are deathly or very scared or avoidant of certain things, people that are afraid of heights or claustrophobic, afraid of enclosed spaces, afraid of leaving their house, afraid of snakes, afraid of spiders. Those are specific phobias, and that's where you know that your anxiety is directed at some object or person or thing or situation specifically. Phobias affect about 8% of the population in any given year. Panic disorder is probably about 4%. The neurotransmitters involved in anxiety disorders are GABA. It's actually an increased sensitivity, although it's lower levels of GABA, because with anxiety, of course, your glutamate and your system is ramping up. That's why GABA agonists like benzodiazepines are the most effective. Sometimes it's also combined with having too little serotonin. So this is where, even though depression and anxiety seem like opposites, right? With depression, you have a lower functioning, less serotonin. With anxiety, your system's ramped up more. This is why they go hand in hand. They actually, you actually see low serotonin in both. That's why a lot of times we have comorbid anxiety and depression diagnosed. And so benzodiazepines are GABA agonists, as we talked about in chapter 5. They increase sensitivity of the receptors to GABA, but you have to be careful because they're very addictive. And if you take them with alcohol, it can be a very deadly combination because you're combining something that shuts down your system with something else that shuts down your system. So it's going to shut it down more. A lot of times, because of this highly addictive property of benzodiazepines, and the newer generations seem to be a little less addictive, which is nice. But SSRIs usually not only relieve the symptoms of depression, but can also help out with the symptoms of anxiety by, again, regulating serotonin levels. So you do see not only a comorbid diagnosis, but some of the same drugs that may work on overlapping systems, like serotonin. Looking ahead, if it lets me, come on. There it is. Another variant of these anxiety disorders is one that is talked about a lot these days, but you may not know much about it. Post-traumatic stress disorder, also known as PTSD, is defined as a prolonged stress reaction to a traumatic event. How traumatic it has to be for you to get PTSD may be a heritable trait. People with that low level, the short allele of the 5-HT-TLPR gene may be more susceptible to something. What you define as traumatic could be different for different people. So people that sweat the small stuff and have anxiety already, the fact that something traumatic could happen that for other people might just be like, okay, that happened and that sucked, but that could be totally traumatic for somebody else. Being embarrassed, getting into a car accident could be enough to trigger someone. For others, it may be as far as like being in a war zone or things like that. So the heritability rate, if you had parents, family members that had PTSD diagnosed with it, is about 30%, and it seems to be unrelated to the severity or reaction to a traumatic event, right? So some people, right, even in a war zone, soldiers that come back from war, only about 23% or so develop PTSD. So it may not be necessarily severity, it just may be genetics and susceptibility to it. The treatment for it a lot of times is that the way that your brain remembers it and is exposed to that, especially in combat veterans or in 2/3, probably 1/3 to 2/3 of prostitutes way. So maybe seeing pictures of the war zone where you were, people who went to Vietnam or Desert Storm or things like that, Afghanistan, and sort of, you know, seeing it in a less abrasive way and being exposed to a little more each time to get used to it, and maybe, you know, sort of tricking your brain into saying maybe it wasn't as traumatic as we originally thought. Um, Virtual reality, by going through it using virtual reality headsets. Fear erasure is very similar to that. These are also possibilities for treatments in which you're basically making that traumatic place or event or thing that happened feel less traumatic over time by messing with the reality of the situation or trying to, you know, lower the level of fear that was associated with it. As far as medication goes, there are medications that people use. One of the medications is called D-cycloserine. And probably the best combination that we've found recently is D-cycloserine combined with a virtual reality therapy, because people feel with virtual reality that it's not really that real, but they can experience it in a different, less harsh way, less traumatic way. And this has been shown to reduce PTSD remission by about 50% after 6 months, which is really, really good. There has been therapy using psychedelic drugs, actually in this case, ecstasy or pure ecstasy, which is MDMA, clinical lab, not like cut in some dude's basement, right? So pure MDMA has been used in 8-hour therapy sessions with patients, and it has been described as a 6-month treatment in 8 hours. So that's really promising if, right, obviously the stigma of doing a psychedelic type of drug, hallucinogenic type of drug is, you know, overlooked. And actually in other types of disorders, things like mushrooms, psilocybin, another hallucinogenic, has been used to help out, but that's for another class and another day. So we can see that in PTSD, not only do you have that traumatic event, which is emotionally and stressful, emotionally scarring and stressful, but you can see actual brain changes due to this. And this is where we know the diagnosis is real, and it's not just people faking it or anything like that. Not that I would ever suspect people do, but you never know how the public takes it, right? People think that masks are ineffective for this time of, I'm not going to get into that. But we may see decreases in the volume of hippocampal cells, right? So the opposite of neurogenesis. And this may be more of a predisposing factor than a result. If they've never been scanned before and they seem to have lower levels, then they probably had lower levels in the hippocampus before the traumatic event, and that sort of led to it being so traumatic for them. We also see decreased activity in the medial prefrontal cortex, which is the middle of the prefrontal cortex, as well as the connections with the hippocampus. So you see in depression, you see in anxiety, overlapping circuitry, right? Disconnectivity or less activity between the hippocampus and the prefrontal cortex. Again, just like we saw in some instances of depression and bipolar, hyperactive amygdala and parts of the limbic system, such as the anterior cingulate cortex and the insular cortex on the underside of the prefrontal cortex. And we see this in twin studies, right? So looking down here, looking at hippocampal volume, you have a combat exposed twin with PTSD, and the unexposed co-twin has similar numbers in the hippocampus. So looking at it, it's probably not a case of your hippocampal cells going down and losing them as a result of this traumatic experience. It's more about having less volume and being more susceptible to the trauma in the first place before any trauma has happened. Looking at a combat exposed twin without PTSD, we again, in the unexposed co-twin who wasn't in the war zone, we again see similar numbers of cells in the hippocampus. So again, nature over nurture. Look at that. Sometimes we see circuits that may contribute to people's anxiety. There have been different ones that have been proposed. And again, don't look too closely into the little itty bitty details here. Just look at the overall picture. The ventral attention network, as you see down here in the ventrolateral prefrontal cortex. So looking here in this area in sort of a blue-green, we see ventral attention stimulus orienting. This network seems to contribute to excessive stimulus-driven attention, so keeping your attention on one singular thing and maybe obsessing over that one thing. There's the salience network. So here, salience network is in purple. So you see here right in the middle in purple, the salience network seems to be some sort of error detection between maybe the intended response and appropriate responses. So whether you are giving the response even though you didn't mean to do it that way, or you're interpreting it differently when someone else responds to you. The frontoparietal network you see here in yellow. Here's the frontoparietal network, these areas here, here, and here. That seems to be executive control over your emotions, your behaviors, control of your environment. Some people that have problems dealing with control, you can see how obsessive compulsive disorder and other things like that may play a role with this frontoparietal network. Feelings of not being in control or needing to be in control of your own situation. And then finally in red, we see here a lot of the medial prefrontal cortex and cingulate cortex is the default mode. So that's the idea of being able to monitor yourself, monitor your planning, regulate your emotions and things like that. So that's very big with the limbic system, the cingulate gyrus, and those networks for being able to check yourself and not be out of your own control, right? So you can see how some of these networks play a role in another type of anxiety disorder that we talk about called OCD. So here in obsessive compulsive disorder, another offshoot of the anxiety disorders, what happens is the obsessive part is actually the recurring thoughts that you can't stop thinking. The compulsions themselves are actually the acts, the behaviors that you do. So if you think about it, somebody that continually thinks after they use the restroom, I'm not clean, I'm not clean, I'm not clean, I'm not clean, and that thought keeps recurring in your head and you can't stop it, you can't check it. Then that leads to the compulsion of washing your hands not once, not twice, but sometimes 6 or 7 times, maybe more. I had a former student in this class last summer, I think, who revealed to me later that he was diagnosed with OCD and that he would wash his hands so much that they would become raw and almost bloody, and he would wash the, for the top layers of skin right off of them, which is, obviously counterproductive, shall we say. So a lot of times what we see with people who have been diagnosed in brain scans with obsessive compulsive disorder, abnormally high activity in a part of the prefrontal cortex called the orbital frontal, orbital meaning like right behind the eyes, where the orbital bone is around the eyes, and in the caudate nuclei, which is part of the striatum. And we see lower activity in the rest of the basal ganglia. So the caudate nucleus has higher activity, the globus pallidus, the putamen, lower activity. So we, again, with OCD, we see genetic association, of course, with other, and we see comorbidity with other anxiety disorders. So generalized anxiety and OCD, right? And this seems to involve imbalanced levels, of course, of serotonin as well, and dopamine. So here you can see in the pictures much higher levels in the caudate nucleus and in the rest of the brain, and in the orbital frontal gyrus, but not in the rest of the brain. So what about treatment for OCD? When we're looking at it, if I can get the computer to move, other variations of OCD that we've seen in animals are excessive grooming to the point of hurting themselves. You may have seen this in animals. I have my little dog that I gave to my brother to not be so lonely and so that she'd get more attention there while we were working a lot here. Shows excessive grooming to the point of almost hurting themselves and getting sores. And this is called acral lick syndrome, seen in this mouse, which involves the lack of a certain gene called the SAPAP or SAPAP3 gene, SAPAP3 gene. So that's another offshoot. We don't normally see that too much in humans to the point where they will groom themselves until they do that. But think about the example I just gave you of OCD and my former student that basically washed his hands raw, right? It's a very big variant, and this is something that you can see in the animal kingdom, because in behavioral studies with animals, you're not going to see a mouse wash their hands 10 or 20 times. You're not going to see them lock a door because they don't have thumbs, but you will see excessive grooming and things like that. So when we look at these things, another disorder that has been added to the DSM more recently in the newest version that we see shows for on the TLC channel and stuff like that is hoarding. Hoarding seems to be another offshoot of an anxiety disorder, another sort of side branch, shall we say, of OCD, in that it's compulsive collecting and over emotional attachment to objects or things. You literally can't get rid of your stuff because you feel like it's a part of you, and it's killing you inside to even part with trash a lot of times, like the boxes that things came in, not just the things themselves, but sometimes even the boxes that they came in and the wrapping. And we see other instances that are related to OCD in Tourette syndrome. So Tourette syndrome is one where you may have seen it on South Park. Kind of made it famous that people will sometimes make a sound or a beeping noise, or they will shout out. They have a sort of a tick that makes them say words that they weren't planning on saying, right? So cuss words a lot of times, bitch, right? And they can't control it. It's sort of a tick. This also shows high dopamine activity in the basal ganglia. Remember that with OCD, we had high activity in the caudate, but the rest of the basal ganglia very low activity. This is sort of the opposite, or reverse OCD. There's too much activity in the other parts of the basal ganglia, causing these motor tics and uncontrollable word cursing and things like that. And I actually had I have a really good friend of mine who grew up with Tourette's. And I think he used to use marijuana to self-medicate, which worked really well for a long time. But he missed an entire year of high school because his symptoms were so bad. He, instead of cursing, would make a very high-pitched beeping noise. So his brain would make him go boop, boop, boop. So he would just be kind of like my email. So he would just be talking and he'd be saying, so today we're going to do boop, right? And then he tried to control it by stifling it, and it ended up sounding like almost like a fake fart noise. And we would have, I knew friends of mine in middle school and high school that used to really make fun of him for that. So he missed an entire year of school, and he really worked on trying to control it. And actually, in the last 20 years or so, when I've talked to him, seen him in person, he's living in Colorado now. I have not noticed any of that. So maybe it got under control. Maybe he helped to self-medicate with THC from marijuana. He doesn't smoke anymore or ingest marijuana now, but I think it was a really big help in helping him overcome it. So that is Tourette syndrome. So looking at, for the last couple slides, I think this may be the last one or two, looking at heritability, ranges between 20 and 47% in twin studies. So if one identical twin has it, the chances of the other one getting it, about 47%, where it's about 20% in fraternal twins with only 50% DNA match. What we do see is that over 90% of people with anxiety disorders have a history, again, of comorbid or other psychiatric problems. The biggest one that goes with anxiety is depression, and we see the symptoms are overlapping, genes a lot of times are overlapping, the brain structures are overlapping, neurotransmitters are overlapping, so the medications overlap. So in major depression in about 50 to 60% of individuals with anxiety disorder, or maybe less depression, right? Again, we have that persistent depressive disorder, which is not pit of despair, but more often than not, more than 50% of the time over 2 years or more. And we see panic disorder in about 16% of bipolar patients. So there's a lot of high comorbidity if anxiety is your base disorder, where depression will rear its ugly head. Um, so let's see. I think that might actually be the last slide. Um, or my computer could be giving me fits, but we'll find out in just a second. If this is the case, which I believe it is, if we can get here, then I will bid you guys adieu. And once again, yep, it is that one. So I will say to you, thank you so much for sticking it out. Obviously, this is what I got my degree in, so this is my favorite subject to teach, and I could teach it over and over again. And I just want to say thank you for sticking it out in this weird semester, and good luck on the final exam during finals week. It will be open on Monday, June 1st, even though that's technically the last day of the semester because next Monday is Memorial Day. But I will open the exam up. So if you want to take it that day, you can. Otherwise, it will be open until Sunday, June 7th. And June 1st is, of course, the day that your final paper, and if you want to turn in the extra credit paper as well, that those are due by just before midnight. So thank you again for such a great semester, even though the circumstances were not the best. And thank you for your time. I appreciate it. And at some point soon, hopefully, I'll talk to you soon.